here today from MidCentral Health with Barb and Lisa, but one of our biggest learnings in this collaborative locally has been that we are an evolving team. So during our process, we have a team of about 8, including pharmacists, medical staff, nursing staff and quality, but we've extended our team now to include dietitians, and we're having regular feedback with our local kamatua, which has been invaluable to what we've learnt. So our aim was to reduce opioid constipation, 50% from baseline in Star 2. Our Star 2 is elder health, and we have 5 under 65 rehabilitation beds. We chose Star because when we originally looked at the surgical areas, the multiple variables influencing constipation in that group, we're really trying to tighten down our population, hence why we went there. Our driver diagram started at learning session 1 when we were all doing our post-it notes. It's since evolved, and even after Prem and John visited, it's evolved again, and we use our driver diagram when we have our monthly team meetings. Our agenda is set against the driver diagram and everybody's responsibility and where we're up to as far as their projects go. I imagine it will continue to evolve, but it's provided quite a useful framework for some of the big pieces of work that we've got going on at the moment. We started off with our PDSAs around the Audit Tool. Our Audit Tool now is probably version 7 or 8 at least, trying to be as specific and again trying to narrow things down with our auditing. We are sadly the poo team. We arrive on the Star Ward on a Wednesday afternoon at 4 o'clock. Part of the philosophy of our collaborative has been having the conversation and promoting the conversation. So lots of the initiatives that we've come about is helping us to understand how this constipation has got to be a problem where it is so everywhere. We're working on a flow chart which is based on, I think it's a Canterbury Palliative Care constipation flow chart. So we took their framework, and our pharmacy and medical team are looking at what we have locally, what is working. It's been signed off. The medical people in our team have taken it to multiple focus groups. They tell us. We think it's probably a beer and a packet of chips. But their focus groups have worked on this, and so now it's going up to the medical heads to see if it's acceptable. And it's been really important when we're working with the staff because they say, so what are you going to do? What do we do when we notice someone's constipated? We haven't got a framework. So this is going to be important. Part of the poo team was thinking about how do we talk about poos? What is the acceptable way? So we came up with these, again, one of the doctors came up with these draft posters thinking about what can we do to encourage the conversation that would be acceptable right across our community. So once they get to Star, it's too late. But also that could go out to the rest homes and the other areas which work really closely with our older populations. We had these ideas and we mucked around with them and thought it was really funny, but we still didn't really understand what the barrier to talking to people around bowels were. We assumed that maybe people weren't talking to us. So we came up with a short survey and we were asking the older adult, were bowel movement conversations, were they an important component of their health? Did they think it was important to talk to us? And did they feel comfortable to talk to us? Could they list any barriers and explain what we could do differently to promote that conversation? And then which poster would they like if we were to go ahead with one of these? This has also gone over, we've had the kamatua were really interested in this conversation because they have identified our Māori population also present much later with bowel cancer, and the disconnect for them. They talked a lot about flush and go and not looking anymore, so they were interested in utilising this as well. When we went down as the POO team to do our audit, there were some students there, and we asked the students if they would be involved, and they've been really keen. They've learned quite a lot about the auditing process, but also got engaged with their clients, asking these questions. So they're working on that while we're here talking to you. We took the work that had been done by Capital Coast around patient information, we took it over to speak to the Kamātua and took it out and made some changes. This is the example of how we rely on so many variables. So the lady from communications who was going to tidy things up so we could present our latest patient information to you didn't get back to us, but I guess that's what we're learning as part of the collaborative. You rely on lots of people to help out, and we need to be patient and adaptable. When John and Prem came, we tried to get as many people from the Star area to come and meet with them. We're really trying to promote the good work that our team are doing there. And up until this point, it's really been the POO team coming on board. Heading back after this meeting, we're going to try and encourage the nursing staff to be more involved in the auditing that we are doing and own some more of their data. There's lots of things that we have found around the constipation. When we said to the doctors, who do you ask about bowels, they said they ask the nurse. And when the nurse identifies that there may be a problem, they then go back to the doctor because nurses seem to have forgotten how to do simple abdominal assessments, checking to see if people are constipated. So some of the work, Lisa as our educator and our team was looking at framing up some education for the staff there as well. We have monthly meetings, we have ongoing email conversations. We're doing our auditing, the flowchart, the patient information, posters, the patient surveys. It's reported through to the clinical board and the head of quality locally. So we've got lots of pieces of work in action, and now we've just agreed, thank you Prem, to start doing our audits weekly because he said that because of we needed to do it more often. We were trying to do it fortnightly, but there is another group we're hoping to bring on and help so we can maintain those weekly audits. Work in progress. Any questions?